afternoon everyone. This is July 2025 TransConnect. I am Dr. Mohit Chaudhary and today in this TransConnect channel we'll be talking about iron metabolism in health and disease with a focus on deficiency and overload. The topic essentially will cover the distribution of the iron, the absorption of the iron, the role of hepcidin in the negative feedback for iron metabolism, the recycling of the iron deficiency anemia, the various parameters that are associated with iron deficiency anemia, iron overload as well, and the transfusional iron overload and how it is caused, along with an emphasis on the chelation and the chelators that are available for iron overload. So over to my colleague Dr. Anand, who is going to take you through this very important topic which is also asked in the DNB exam as well.
A very warm welcome to one and all of you. The topic of discussion for today is iron metabolism in health and disease with a focus on deficiency and overload. Iron metabolism refers to the complex system of processes that regulate the absorption, transport, storage and utilization of iron in the human body. Iron is primarily involved in oxygen transport, which forms a key component in hemoglobin of RBCs. Muscle function, myoglobin, which is another iron-containing protein, stores and releases oxygen in muscles. Enzymatic functions include iron as a cofactor for various enzymes involved in energy metabolism, detoxification and DNA replication. And finally, the normal body iron concentration is approximately 40 to 50 mg per kilogram of body weight. Women have comparatively lesser iron storage than that of men. Coming to the distribution of iron, iron is present in hemoglobin, which comprises of 30 mg per kilogram. Iron is also present in heme compounds like heme compounds, myoglobin and cytochromes, which comprises 5 to 6 mg per kilogram. And finally, the iron stores as ferritin and hemochromatosis comprises of 5 to 8 mg per kilogram, in total contributing to a total iron distribution of 40 to 50 mg per kilogram. Coming to iron absorption, iron is absorbed in duodenum and upper jejunum of small intestine. It exists in two dietary forms, namely the heme iron and the non-heme iron. Heme iron is obtained from animal sources and are more efficiently absorbed, whereas the non-heme iron obtained from plant sources are less efficiently absorbed. Key factors influencing absorption of iron are enhancers are vitamin C and stomach acid pH, whereas the inhibitors are phytates, calcium and tannins, which is present in tea. Therapeutic iron salts are well absorbed when taken in empty stomach. Dietary iron absorption depends on amount of iron in diet, bioavailability and body's requirements. Iron balance is maintained by controlling iron absorption. Iron stores and iron absorption are strongly closely correlated, so that when the stores are depleted, absorption increases. So this is the diagrammatic representation of iron absorption. As we know, the food iron contains iron in the form of heme iron and the non-heme iron. Heme iron is absorbed directly into the enterocytes by the heme transporter, which is present in the luminal side of the enterocytes, whereas the non-heme iron, which exists in the ferric Fe3 plus form, is first converted to ferrous Fe2 plus form by the duodenal cytochrome B, which is also present in the luminal side of the enterocyte. The ferrous form is transported by divalent metal transporter 1 DMT1 into the enterocytes. Inside the enterocytes, the absorbed iron exists in the form of mucosal ferritin. This mucosal ferritin may be lost by shedding of the epithelial cells. The stored iron inside the enterocytes is further transported outside the enterocytes through transport protein called ferroportin 1, which is located in the basolateral side of the luminal enterocytes. The basolateral side also consists of a protein called hepcidin, which converts the transported ferrous form back to ferric form. The converted ferric form is further transported into the blood and is bound to the plasma transferrin. The transporter ferroportin 1, which is a major transporter and plays a key role in iron absorption, is under the negative influence of hepcidin. Coming to the factors that affect the cellular uptake of iron, the transferrin iron complex binds to transferrin receptors and is internalized via receptor-mediated endocytosis. Iron is released from transferrin in acidic environment of the endosomes. The delivered iron is used up for various cellular and enzymatic functions. Excess iron is stored intracellularly as ferritin or hemochromatosis in cases of iron overload. Regulation of iron absorption and the role of hepcidin. iron absorption is modulated by several systemic signals and conditions. Hepcidin is a key regulatory hormone produced by liver which binds to ferroportin, causing its inhibition. High levels of hepcidin hence causes reduced iron absorption, whereas low levels of hepcidin causes increased iron absorption and mobilization. Body iron status. When there is an iron deficiency, there is reduced hepcidin levels and increased DMT1 and ferroportin expression, which causes increased iron absorption, whereas in iron overload, there are high levels of hepcidin and reduced transporter expression, which causes reduced iron absorption. Erythropoietic demand. Increased erythropoiesis causes reduced hepcidin levels and increased iron absorption. Coming to inflammation, interleukin 6 from inflammation stimulates hepcidin production, which causes reduced iron absorption, contributing to anemia of chronic disease. Now coming to iron recycling mechanism. The iron recycling mechanism conserves iron in the body by reclaiming it from senescent RBCs. Body doesn't have an active iron excretion system. Hence, recycling is essential to maintain iron balance and to support the ongoing erythropoiesis. Senescent RBC are phagocytosed by macrophages in spleen, liver, and bone marrow. Hydrolytic enzymes in macrophages degrade the ingested RBC and release hemoglobin. Proteolytic digestion of hemoglobin release heme and globin. Globins are broken down into amino acids which can be used for protein synthesis. The iron is released from heme, leaving a porphyrin ring which is converted to bilirubin. Once iron is released from the heme, it is either utilized by the cell for production of iron-containing enzymes and proteins, or it is released and exported via ferroportin or stored in the form of ferritin. Now focusing on to iron deficiency. Iron deficiency occurs when the decrease in total body iron content is severe enough to reduce erythropoiesis and cause anemia. About 20% of iron is absorbed from food. The recommended daily allowance RDA for all age groups of men and postmenopausal women is 8 mg per day, while the RDA of women of reproductive age is 18 mg per day. The maximum tolerable upper intake level of iron for adult is 45 mg per day. The value is based on GI distress and the adverse effects that is caused due to excess iron. Markers of iron deficiency. Iron deficiency can occur in stages progressing from depleted iron stores to iron deficiency anemia. The key biomarkers used to assess iron status are: first one is the serum ferritin level, which reflects iron stores in the body. Low ferritin levels below 30 nanogram per ml indicates iron deficiency, whereas the values below 15 nanogram per ml is highly specific for depleted iron stores. Ferritin, being an acute phase reactant, can be falsely elevated in inflammation, masking iron deficiency. Serum iron measures the amount of circulating iron bound to transferrin. Serum iron levels are low in iron deficiency. The third marker of iron deficiency is the total iron binding capacity TABC, which measures the capacity to bind iron with transferrin. High TABC suggests low iron stores, which reflects increased transferrin production by liver in iron deficiency. Transferrin saturation indicates the percentage of transferrin binding sites occupied by iron. It is calculated by serum iron divided by TABC into 100. Low transferrin saturation is typical in iron deficiency. Soluble transferrin receptors reflects the cellular demand of iron and erythropoiesis. It is elevated in iron deficiency, and its advantage is that it is not influenced by inflammation, unlike ferritin. The last marker is the reticulocyte hemoglobin content, which measures hemoglobin content in new RBCs. Low levels suggest functional iron deficiency affecting erythropoiesis. So this is a summarized table of markers of iron deficiency and the changes that can be seen in iron deficiency. We can see that serum ferritin is the most specific marker that represents the iron stores. Coming to red cell indices in iron deficiency. Red cell indices include MCV, MCH, MCHC and RDW. MCV is the mean corpuscular volume, which is the average size of red blood cells. In iron deficiency, the RBC size are reduced, leading to microcytic RBCs. MCH is the mean corpuscular hemoglobin, which is the amount of hemoglobin per red blood cells. In iron deficiency, the hemoglobin content is reduced, leading to hypochromic RBCs. MCHC is the mean corpuscular hemoglobin concentration, which is a hemoglobin concentration in a given volume of red cells. MCHC may be reduced or normal in iron deficiency, while RDW is the red cell distribution width, which is a variation in red blood cells. In iron deficiency, there is marked variation in RBC size leading to anisocytosis. Now the another spectrum, which is iron overload. Iron overload is a condition in which excess iron accumulates in the body, leading to tissue damage and organ dysfunction. Body has no natural mechanism for actively excreting excess iron. It can build up over time if absorption or transfusional input exceeds the body's need. Primary iron overload is due to hereditary hemochromatosis, whereas secondary iron overload can be due to multiple reasons. Chronic transfusions, which are usually done for thalassemia and sickle cell patients, chronic liver diseases like hepatitis C and alcoholic liver disease, ineffective erythropoiesis due to myelodysplastic syndromes and various other conditions can cause increased iron absorption due to excess expression of hepcidin. Hereditary hemochromatosis and its various types. Type 1, which is a HFE gene related, is a classic form of hereditary hemochromatosis. It is due to mutation of HFE gene on short arm of chromosome 6. It is an autosomal recessive inheritance. Type 2A and type 2B. 2A is due to mutation of the hemojuvelin gene and 2B is due to mutations of the hepcidin gene. It has autosomal recessive inheritance. Type 3 is due to mutations of transferrin receptor gene. It has an autosomal recessive inheritance. And finally the type 4, which is due to mutation of ferroportin gene in SLC40A1 gene. It has an autosomal dominant inheritance. Storage iron is present in form of ferritin, which is a soluble form, and hemochromatosis, which is the insoluble form. Under normal physiological condition, iron is distributed equally, but as the body's iron load increases, the proportion of iron stored as hemochromatosis increases. Coming to the differentiating features of primary and secondary iron overload. The cause of primary iron load is mainly genetic due to HFE gene mutation, whereas in secondary it is acute due to transfusions and liver disease. The hepcidin levels are low due to genetic mutation in primary, whereas the levels are high or low depending on the cause in secondary overload. Iron source is due to increased absorption in primary overload, whereas in secondary it can be exogenous in case of transfusions and endogenous in ineffective erythropoiesis. Transferrin saturation is more than 45 to 50% in primary overload, whereas the saturation levels may be normal or high in secondary overload. Ferritin levels are moderately elevated in primary and the ferritin levels are very high in secondary iron overload. The treatment modality is phlebotomy for primary iron overload, and iron chelation therapies are used as a treatment modality in secondary iron overload. Coming to genetic testing. Genetic testings are usually positive due to HFE gene mutation in primary overload, whereas in secondary the genetic testing is negative, and the age of onset is usually seen in middle age groups for primary overload, and the secondary overload cases age of onset may be childhood or adult. It depends upon the cause. Transfusional iron burden refers to the accumulation of excess iron in the body resulting from repeated blood transfusions. Each unit of transfused blood contains a significant amount of iron, which can lead to iron overload, especially in patients who are transfusion dependent. 1 unit of PRC approximately contains 200 to 250 mg of elemental iron. Since there are no means of excreting the excess iron is also inapplicable to phlebotomy. Patients requires iron chelation therapy as treatment for transfusional iron burden. Organ manifestations of iron overload. Iron overload leads to toxic accumulation of iron in tissues. When transferrin becomes saturated, non-transferrin bound iron circulates freely in the circulation. Non-transferrin bound iron generates reactive oxygen species, which causes oxidative damage, fibrosis, and ultimately organ dysfunction. Coming to the organ manifestations, liver is the most commonly affected organ. Hepatomegaly, elevated liver enzymes, hepatic fibrosis and cirrhosis, and ultimately increased risk of hepatocellular carcinoma is seen due to iron overload. Coming to cardiac manifestations, there may be restrictive or dilated cardiomyopathy, arrhythmias, congestive heart failure, sudden cardiac death. Cardiac manifestations are usually seen in transfusion dependent anemias like thalassemia major. Endocrine glands. In pancreas, there is an induced beta cell damage causing diabetes mellitus, commonly known as the Brown's diabetes. Pituitary, there is hypogonadotrophic hypogonadism, there can be hypothyroidism, hypoparathyroidism, and adrenal insufficiency also in rare cases. Coming to joints and bones, there is iron induced arthropathy which affects the metacarpophalangeal joints, knees, and hips. Osteoporosis or osteopenia may be also seen. In immune system, there is increased susceptibility to infections, especially by Yersinia, Listeria, and Vibrio. In skin, there is bronze or grayish pigmentation. Assessment of iron overload. Liver iron concentration reflects the total iron burden in body. MRI-based methods are non-invasive and are widely used for the liver iron concentration assessment. LIC, liver iron concentration more than 5 to 7 milligram of iron per gram dry weight is significant in iron overload. Liver biopsy is the gold standard method. It is used to assess fibrosis and cirrhosis. Cardiac MRI detects the iron deposition in myocardium. It is important in transfusion dependent anemia patients. T2 MRI less than 20 milliseconds indicates cardiac iron loading, whereas T2 MRI values less than 10 milliseconds has high risk of heart failure and arrhythmias. These are the assessment methods of iron overload. Serum ferritin, which is a marker of iron stores, is elevated in iron overload. Transferrin saturation, which is indicative of the iron transporting capacity, is also elevated in iron overload. Genetic testing, which is done for diagnosis of hereditary hemochromatosis. HFE gene mutation is most commonly seen in primary iron overload. As we have mentioned before, organ manifestations, we can do MRI for liver and cardiac MRI to assess the hepatic and cardiac manifestations of iron overload. CBC and LFT can be done to assess the general health and liver functions. And finally, the endocrine profile can also be assessed to detect the organ damage due to overload. And finally, the management of iron overload. Goals of management are to prevent tissue deposition of excess iron, to maintain balance between amount of iron entering the body and that is being removed by chelation, and to monitor the rate of iron loading. Monitoring of iron burden can be done through serum ferritin, which the testing should be done once in every 3 months, and the target value of serum ferritin should be maintained less than 1000 nanogram per ml. Liver MRI for liver iron concentration is done annually. Cardiac MRI should also be done annually. CBCs and LFTs can be repeated periodically to assess organ functions and to detect early manifestations. Iron chelation therapy. Iron chelators bind to excess iron and promotes its excretion through urine or feces. The choice depends on patient's age, iron burden, cardiac risk, and tolerance. The ideal iron chelator should form a high affinity complex with iron, should be able to chelate intracellular iron, be orally effective with long half-life, should have a low toxicity profile, and should be effective in removing iron from all age groups. Deferoxamine, deferriprone, and deferoxirose are the most commonly and widely used iron chelation agents. The choice of agent among these three depends upon the general condition of the patient and the organ manifestations. That's all for the topic, and thank you everyone for your patient listening.